Hi everyone, today I'm presenting on the family health promotion theory, also known as family health promotion model. This presentation will cover four areas: where the theory comes from and its key concept, and how it's applied to the four core nursing concept to the family, and how nurses use it in the practice to assessment and intervention, and the two research evidence that support it. The central idea is in the theory shift our focus from the individual to the family as a whole. In this slide, into the family health promotion and so where the theory comes from. Family health promotion model from 1996 focus on the individual is at why one person chose to act on their health. It look at prior behavior, personal belief and perceived benefit and barrier, self-efficacies and influences from the other people and environment. In 2004, Loveland-Cherry and Bomar took the model and applied it to the whole family. Family health promotion is about activities families do together to strengthen their family unit and improve their quality of life. Instead of asking why one person acts, we now ask why a family act together. Families shape health through a shared beliefs, daily routine, and how they talk to each other, the support they give, and the habits they pass down to next generation. All of this also shaped by the system around them, from home and school to the wider community. As nurses, our job to help family attain, maintain, and regain their higher level of health they can, working with them as a unit, not just a one person at a time. In this slide, the figure represents the core process of the family health promotion model created by Loveland-Cherry in Bomar 2004. The model proposed the health promoting behavior do not occur by chance, but develop through an interaction and several family factors. It all starts with a family general influences. These are the family system patterns, its demographic background, and its biological makeup. System patterns are things like family values and how they communicate and how they relate to one another. For example, a family that talk openly about the feeling may be more willingly to seek counseling when someone is struggling with anxiety or depression. Demographic factors like culture, income, and family structure matter too. And biological factors include genetic risk and family health history. These family general influences then shape the family health related influences. That cover how the family learn about health and how they define health and how healthy they believe they are. For instance, one family may see health as a simply not being sick, another may see it as a physical, emotion, and mental well-being altogether. Parents who exercise and keep up with the preventive care tend to pass those habits on to the children, and that builds on healthy pattern over the time. Next come to the behavioral specific influences. These decide whether the family will actually follow through. Think about the barriers and benefits they see, the past experience, their family norms and their support system, and the situation they in. For example, a family may know that there we could improve the communication, but problem like transportation or lack of time can get in the way. On the other hand, support from the school, community agency, and healthcare provider make it more likely that healthy habit will stick. All of these factors lead to the model meant outcome, how promoting behaviors. That means things like eating well, staying active, managing stress, taking medication as prescribed, and communicating well as a family. The model also reminds us that internal family and environmental cues, such as encouragement from the loved one and reminder from a provider, help keep the behavior going over the time. So to sum it up, the model follows a simple chain. Who the family is shaped what the family believes, what they believe shape what they do, and what they do shape the family overall health and well-being. As a future PM at MP, I really value this model because it pushes us to build on a family strength and grow their resilience instead of focusing on the illness or what's going wrong. This slide looks at the four core ideas in nursing, which together call the meta paradigm, and it will each one through the lens of the family. We start with the person. In family nursing, the person is not a single patient, but the whole family. And the family is really whoever its member say it is. Families stay well by sharing with each other, making decisions together, and giving everyone a sense of belonging. Health comes next, and it means much more than simply not being sick. Health is whole and it shifts over the time. It is the everyday work a family does to live well, and each family decides for itself what health really means. Then this environment, which is simply the world the family lives in, They include their home, their neighborhood, their job, and their income, as well as whether they can access the clean air, safe housing, and healthcare. When these everyday things are fair and within reach, family thrive, and when they are not, health suffers. Finally, nursing ties it all together, and it is very much a team effort. We do not manage health for the family, we do it with them. We help them see whether their health stand and what goal they want. We connect them to the resources and advocate for them when the systems are hard to navigate. And we teach them in a way that respect their belief, their culture, and what they can afford. So the one thing to remember is that every idea here comes back to the family in real life. So how do we apply this? The model is fundamental strength-based. Rather than focusing on what's wrong, the nurses focus on the family strength, resources, and resilience, working in collaboration to empower the family. The nurse role is to assess the family health belief, their interaction, the barrier they face, and the strength they already have, and then to set goals with the family, not for them. This is about getting to the root cause of the deficit and building on what the family already does well. The care plan is clear, logical, and communicated together with the family. This slide covers the three core family health promotion model-based interventions, and all of them are family-driven. The first is the family self-care contract. This is a written agreement where the family identifies their goals, assign responsibilities so each member is accountable, set a champ phase and an evaluation plan, and can modify or negotiate as things change. The second is a family empowerment. Instead of focusing on what family cannot do, this approach builds on the existing strengths. It involves education, skill building, and positive reinforcement, using the resources the family choose for themselves. The third is the routine and ritual. This means respecting the cultural and personal ritual that already hold the family together, promoting stability and bonding, and building in a shared routine like family mealtime, with result linked to the fewer health risks in the children and teens. The pattern across all three is the same: family leads and the nurse facilitates. The first research study, this study is by Pocha and colleagues published in 2018 in Biological Nursing Journal, applied panda health promotion model to a real clinical populations. The researchers studied 177 adults with type 2 diabetes from primary care center in Bali, Indonesia. Using the threshold equation modeling, they tested whether the personal factor, self-efficacy, and family support predicted how well patients manage their own self-care. The result was striking. Family support was by far the strongest predictor. Personal factor like education, social, economic status, and illness perception also matter, but self-efficacy on its own had almost no effects. This is the key point. We often assume that if patients just believe in themselves, they will manage their health. The study showed that family support matters more. When the family is involved, patients follow through. When it is not, they struggle. This is the family health promotion theory in action. The family is not just a background, it is the engine that drives the health behaviors. Alright, the next study is especially relevant because the Chen and colleagues set out in 2018 to test the family health promotion model directly. They worked in 86 families whose children had a Duchenne muscular dystrophy or spinal muscular atrophy. These are progressive muscle conditions, so the family were living with the real ongoing stress. In total, 113 people took part, including parents, siblings, and patients themselves, and caregivers. Using the threshold equation modeling, the team tested whether the core variable in the family health promotion model actually predicted family health behavior, and they did. Family support and family resilience emerged as the key mediator. Together, they shape both how well a family functions and how actively it works to promote health. Income and geographic matter too. We fit the model attention to social and environment factor. In the end, all four hypotheses were supported. This is strong evidence that the family health promotion model holds up as a causal model, not just a helpful framework. At Inertia, they tell us exactly where to focus. When the strength in the family support system and its ability to bounce back, we are building a very thing that drives better health. In conclusion, the family is the central influence on the health behavior, and the health promotion happens within the family system, not in the isolation. As nurses, we should assess the family's strength, resources, and barriers, and set goals with the families. And the two current researches consistently confirm that family-centered intervention improve and sustain outcomes. For my own family assessment project, I'm applying this model because it gives me a comprehensive family unit framework. It directs my assessment toward the family strength and supports so I can build on a care plan that fits the family's own needs and goals rather than confirming deficits within one individual. And these are my references. Thank you for listening to my presentation today.